Good morning, everyone. Happy Saturday, happy Easter Saturday for those of you who observe Passover and Lent season. I am Ginger Davis, president of the Sickle Cell Thalassemia Patients Network. We are back with our monthly Community Connections Support Interactive, which was developed at the height of the pandemic in 2020 in order to stay connected with our community. To continue the education, the outreach, and support for individual families living with sickle cell disease. We have kept it because the outreach, particularly because we go live on Facebook, which we are right now. So good morning to everyone on Facebook, being able to share this information globally and to support and be there for everyone with sickle cell disease, no matter where in the world they are. Today, we have a wonderful guest. She's just absolutely amazing. Her name is Dr. Ivy Sunkwal. She is a pediatric hematologist for sickle cell disease. And I'm going to let her, talk about her background, both her education and her work. And, why we have Dr. Ivy today is because she has a global view and experience with sickle cell disease, and we really wanted to touch on points of international access, and nobody better than Dr. Ivy to have that conversation with. So good morning, Dr. Ivy.
Good morning, Ginger. Good morning, everybody. So it's great to be here. My name is Ife Osumkwo. I am, the new term for what I do is called a lifespan hematologist, because even though I'm trained in pediatric hematology, I, over the course of my career, branched out and started doing adults for the past 10 years, or the last 10 years of my clinical career. 18 to 82 was my oldest patient. But let me share a little bit about myself. But before I start, I do want to say that this is, what I say in this webinar is Dr. Ife's views, my personal perspective, knowledge, and experience. It has nothing to do with my employer, my company, or anybody else. And so I just want to put that disclaimer out there. Plus, I am not your doctor. So I'm giving you information, but I'm not in charge of your medical care. So please take the information and check with your physician to make sure that any recommendation we discussed today is applicable to you. So as I had told Ginger earlier, I was born in New York City. So I am from the Bronx, yay. And I left and moved to Nigeria when I was 7 and did my medical training in Nigeria. So 20-something years in Nigeria, then came back and then did my fellowship and residency training in the US. And so I do have a perspective that is a little bit broader than what we typically see in the US. I've taken care of sickle cell disease in America, sickle cell disease in different countries in Africa, especially in Nigeria. And I've also interacted with people around the world, Australia, Europe, the UK, the Middle East, India, et cetera. And sickle cell is a global disease. The map behind Ginger shows you that sickle cell is in every continent, every country. And so it cannot be confined to just a US problem, it's a global problem. So that's the first thing. And so as a lifespan hematologist, I also want to share that sickle cell is complicated. It's a very, very complicated disease. One gene, one amino acid change on a single gene that was mutated leads to a myriad of problems. And sometimes we oversimplify what it is, both as patients, providers, and advocates. And I was also sharing earlier that no presentation is textbook. No child or adult with sickle cell disease comes into the clinic and just follows the book the right way, how we learned about it in school. And so there's a lot of understanding and communication that has to happen between the medical community and the patient community so that we can understand each other and appreciate that when we say that when you meet one sickle cell person, you meet one sickle cell person, that is actually very, very true. Now, the more you see people with sickle cell disease, you can pull from 5, 10 different cases to help you solve one case. So there are significant differences, and there's a lot to learn about sickle cell disease and how having sickle cell applies to real life. So think about it. You have sickle cell, but you're also a human being, a female, a mother, you have a job, et cetera, you have children. So your medical presentation is not going to only be sickle. It'll be sickle cell in a 30-year-old female who has children, who has had other maybe medical experiences. And so we have to not look at sickle cell in isolation. And I'm sure there's going to be more questions that come up because I want my colleague Tanya to introduce herself off camera. The other thing I want to say today is that as we think about how to solve sickle cell challenges, both in the US and globally, we have to realize that the rules have changed over time. And I use the term, you can't go to a gunfight with a knife, right? You want to have the right tool to address the right problem at the right time in the right way. Otherwise, we're not going to reach the goals that we want to get. And we have to learn. We have to learn about these new tools that we need to solve for the current problems that sickle cell people experience. And so I'm going to have Tanya introduce herself. Tanya?
Sure. I hope everybody can hear me. I'm Tanya Braley, and I've had the pleasure of working with Dr. Iffy for over a decade or so, almost 2 decades, which is really scary.
So she knows all my crazy.
I'm actually a licensed clinical social worker by trade and have spent 20 years specifically in sickle cell, so both in pediatrics and adult care. So I think we kind of balance each other off in terms of the provider perspective and then the psychosocial perspective and how that, how the disease, how life in general impacts individuals living with disease in different ways, right? And I think Dr. Iffy spoke on that. Just kind of everybody is very individual, just like we have to consider a patient or a person, a 30-year-old mother who's had previous medical issues. We have to look at that from a psychosocial perspective as well. Am I working? Do I work? How many jobs do I have? Can I get to doctor's appointments? Can I access medications? Things like that. So we have been able to, I think, I guess, honestly, pick a really good balance in terms of the provider perspective from both a US and a global perspective, and then the psychosocial piece. So I'm happy to be here this morning, and I'm sorry that I'm not on camera.
That's okay, Tanya. We're just glad to have you here and to have your voice part of this conversation. So Dr. Iffy, let's talk about the fight and the proper tools. What are some of the things that you're finding that both the medical professional and the sickle cell community need to have to get what we need that we don't have? What are some of the things that need to be constructed for us to come to the age of technology and take advantage of all of the things that are happening now? What tools do we need to start developing in order for that to happen?
So I'm going to start with the providers. I want everybody to understand that when you go into medicine because you believe in the Hippocratic Oath to do no harm and to do good in any specialty that you belong to. That's everybody's intent. Medicine is probably the most emotionally and cognitively tasking careers that you could ever go into, because you are responsible for the life of people. At the end of the day, if something goes wrong with a patient, the doctor is the top of the chain, and all the blame goes to the doctor. So that's a huge responsibility, huge responsibility. And when I was a kid, my doctor did home visits, would see 3 people, 4 people a day, and be able to pay their bills and still live a decent life. But today, healthcare has changed to where it's not structured to allow somebody with that much responsibility, that much of a burden, to work in the space that allows them the luxury of time to be empathetic, time to communicate, time to take risks, knowing that it's a calculated risk to try something new to help somebody in the hopes that it may work, time to double check, triple check, and call around and ask for help. So the luxury of time to do the best care is not there, okay? But nobody goes to work every day, I don't care what career you're in, with the goal being to screw people. But at the end of the day, human beings are inherently self-preservationists. They want to protect themselves. So many providers, when you see them in clinic, they are scared. They are afraid of doing the wrong thing, of making a mistake, of getting sued, or killing somebody. That's what drives a lot of the outward expression that you see when you go to see a provider. It doesn't even have to be a sickle cell provider, any field of medicine. For those of you who have other medical illnesses, I'm sure you know that it doesn't matter what disease you have. If you go to the doctor, there's these issues come up, right? So the first tool that we need is to figure out how to address the fear and anxiety that healthcare providers live with every day around providing the best care. And that requires change in the healthcare system that they operate in. That requires change in the burden of responsibility that they have. That requires change in the tools that they're given to know how to use limited time to achieve a maximum reward. We are not taught quality improvement in school, at least I wasn't taught. We are not taught how to communicate well with different types of patients. We are not taught how to be efficient in the practice of medicine, and so without compromising medical care. We are not taught how to do a really good job with reading body language and understanding nonverbal cues. Some people have it as part of their nature. Some people don't. Some people have to learn it, and it's a process. And so I want to lay the stage to say that, yes, there's a lot of injustice in healthcare, and doctors are ultimately responsible. But that responsibility is also part of the problem. And so how do we solve for that? Is that we need to figure out how old doctors and emerging doctors address this responsibility burden and how it impacts how you show up in clinic. I mean, even simple things like leadership training for all medical providers will help you understand how to function well under pressure in terms of how people perceive you. We function under pressure by being very autocratic, very command and control-ish, which is not the best way to interact with patients. When you challenge my knowledge and my skills and my ability, I don't react to you because I think you're making fun of me. I react to you because I'm afraid that you're right. And I'm afraid that I really don't know, but I'm supposed to know. That's my job. I'm the doctor. This is my responsibility. How do I handle that? And what it comes across is autocratic, a bad bedside manner, forceful and negative towards the patient. So that's kind of like one area. The other area is education. I don't know how much you guys think we learn about sickle cell disease in medical school, but it is a rare disease in America. It's even a rare disease in the medical textbooks. We had a big old party a year and a half ago when they published the first sickle cell textbook. The first sickle cell textbook that I have seen in my career of 35 years. I bought like 20 copies and gave to all my friends who were doctors, because I was like, this is great, this is great. But if you don't have the textbook, where are you getting your knowledge? Where are you getting your information? If you don't have a lot of exposure to the population, where are you getting your skills to be able to know how to take care of the population? And remember, it used to be a pediatric problem. And so the adult doctors never had to deal with it. It wasn't an issue. So it was okay not to have a textbook because, the PEDS folks, they know what they're doing. They've been in this for a while. We don't have to worry about it because there's not going to be a 30-year-old, a 40-year-old, or a 50-year-old. So we have to begin to spread the word that there are more adults with sickle cell disease than there are children in the US. But across the world, it's mostly a pediatric disease. And so how do you balance that? How do you share information about the evolution of the disease, the epidemiology, in a way that is innovative, encouraging, stimulating, et cetera, so that they begin to understand? And now the other thing to remember is if there was not a lot of sickle cell disease knowledge for adults, you as an adult individual with sickle cell disease, they don't know how to take care of you. I'm sorry to say this. Many doctors have no idea what to do with an 81-year-old with sickle cell disease. Do I worry about the 81-year-old issues or the sickle cell disease issues? Or none of it? And then, maybe they don't even have sickle cell disease because they're 81. Like, we have these real challenges. And so the mindset needs to be, I have sickle cell disease, but I'm also a human being like everybody else. And the same way you take care of everybody else, take care of me. And on top of that, factor in the sickle cell. It's not a black and white line. If I have a stroke with sickle cell disease as a 35-year-old, it could be a sickle cell stroke, but it could be an adult stroke. But you gotta treat both because I have both conditions. right? If I have hearing loss as a 60-year-old, it could be from sickle cell disease, but it could be from something else. And you can't say, well, go meet your sickle cell doctor to take care of your hearing loss. Like, okay, that's hematology, right? I don't know how to do hearing loss. I need a good primary care doctor and I need a good ear doctor, right? If you have high blood pressure, the hematologist doesn't really know how to manage that very well because we are focused on the sickle cell piece. You need your primary care doctor too. So learning how to share the patients appropriately and supports the patient's well-being together is part of that education that is needed, and so there needs to be almost like a campaign that is grassroots driven by the patients. You deserve good care. You deserve the best care, and the best care for you is when you have a sickle cell expert balanced with your primary care or your medical expert working together to figure out what's going on with you and helping you achieve your best life. It can't be only sickle cell provider, and it can't be only primary care provider. And then when you have pain, they pump you over to the hospital. That's not the best way to do sickle cell disease care, because if you only have your care managed when you're sick, you're missing out on primary care. I mean, this morning I was thinking to myself, I have this back pain when I sit down for a long time. I'm Googling, what is it? And I'm thinking, okay, should I call my doctor? I don't want to take any pain medication, but what, should I do stretches? So overall, I'm very healthy, but I have back pain. That's not going to be my pulmonologist. That's not going to be my eye doctor. That's going to be my primary care doctor. And people with sickle cell disease can have the back pain that comes with getting old, just like, my back pain is from getting old. I'm wearing high heels. It doesn't respect your diagnosis. You can have adult issues with sickle cell disease and adult issues without sickle cell disease. I had a patient once who was bleeding a lot in her menstrual cycle. And she came to me and said, Dr. Iffy, my GYN says I should come to you because this is sickle cell. And I'm thinking to myself, how on earth is menstrual bleeding a sickle cell problem? So I call my sister who's a GYN and I say, hey, what do I need to do? And so she tells me what to tell the patient. And I tell the patient, you know what, go back to the doctor. If they don't do right, fire him and get another doctor. So we have to make sure that people understand that we got to look at you as a whole individual, not you're a sickle cell. Because there's more to you than just sickle cell. It's you with your sickle cell, you as a person, and then you with your other medical challenges. So the other question you asked, Ginger, is what do the patients need to know? And this is where I think that because of how significant the challenges are in sickle cell disease, the patients have to take ownership and responsibility of driving change within the patient community. And what change needs to be driven? You need to educate yourself about sickle cell disease, not just your sickle cell disease, but about sickle cell disease in general. And the reason I say that is when you're 10 years old, you have one set of challenges. When you're 20, you have a totally different set of challenges. When you're 30, when you're 40, when you're 50, you don't know when you're 30 what you're going to do when you're 50. But you need to understand what happens across the spectrum so that when it comes, you have that knowledge. Because otherwise, you're going to have a blinder on and you're going to be talking to yourself, this is my issue. Because that's what happened when you were 30. Now you're 35. And it may be something completely different. And the doctors may not know. So they're going to have to depend on you to point them in the right direction. So don't keep yourself only focused on how sickle cell impacts me historically. Because you may have other things you experience in 10 years and 20 years. And if you don't know about them, when it happens, you will still blame it on how sickle cell had affected you 10, 20 years ago. So I want you guys to broaden your scope of awareness and education about the disease beyond your own individual struggle. Also, because you educate other people, you need to know so that you can share with them what you know. It may not affect you. It may affect somebody you know, and they will learn because you know better about the overall disease. How do you get that information? Sessions like this, talking to people, talking to experts, looking at the book, the textbook, finding out what's out there in terms of new and accurate information and sharing it, but really go beyond, I know myself, I know my disease, this is how it affects me. Because trust me, I have done that with my patients, and I am always surprised because something that is not expected may happen, and if we're not paying attention, we lose it. Okay. The other thing that you need to do is figure out or accept the fact that it's all about resources. Resources is time, people, and money. Doctors don't have the time, they don't have enough people, and sickle cell doesn't pay well. Okay, both in America, in Europe, and you can imagine what it is like in Africa, right? It's time, resources, and people. So how do you get more time? You only have 24 hours in a day. The way to buy time is to do things more efficiently. Ginger, you shared with me that you guys were thinking about doing echo clinics, and you found out that there were 2 other clinics happening in your region. And what did you decide to do? You're going to band with them. That's called efficiency. When you become more efficient, you can achieve more things and reach more people. That's what we need to do. It can't be that everybody starts something individually and has a one-man shop and runs their thing, and they're struggling and fighting and getting worn out because they're doing it all by themselves. We need to know what everybody is doing, and we need to all band together and find the most effective and efficient way and following up with that way. Because if we do things in silos, we're wasting time, wasting resources, and wasting money. Okay, so banding together, being more efficient, finding out how to advocate for money, but not $1,000 here, $1,000 there. There are 3 bills in Congress. If everybody with sickle cell disease, every single 100,000 of y'all wrote a letter to your congressperson, that bill will get passed. And you got all your family members to write, your kids, your grandkids, that bill will get passed. But if the voice is not unified in the community, divided we fall. We need to hear about sickle cell disease as a unified voice. And so SCTPN can combine with SCDAA, can combine with SCCC, and all of you support the bill that is going to help provide resources, time, and money for sickle cell disease care. That would generate momentum and then push it across the finish line. Because how did cystic fibrosis get their funding? Those people, they locked arms and they were like, we're going to get this. And they locked arms together as a community. There were many, many groups, but they came together for the funding struggle, and they pushed it across the finish line. That has to happen in sickle cell disease. But the only way for it to happen is you got to know what's going on, and you got to share that. You got to think about how can we creatively band together. It's an ego-free operation. It can't be that I want my own, I want my name on it, and I want my name on that. It has to be that it doesn't matter which group I belong to, we're supporting this bill. And we're going to do our part and rally our family members. I mean, there's a lot of Black folk in this country. We can do this.
So I got to stop you there because, and I don't want to say it, I have, we're doing that in New York, and we're banding together, and we are a statewide network. And I have, the president and executive director of a chapter and affiliate here in New York, and Tony represents our newest affiliate. And we just finished going through that cycle.
Good.
So Gladys or Juanita, if you'll want to chime in on.
But this is beyond New York.
It is, no, but what I'm saying is we were not together before last year. We weren't. Everybody was working in their silos, and we had the egos going on. And people, when we say come join us in doing a collaborative grant thing, somebody wants, most of the money. And so that has changed within the last year. We have built a statewide network. Not only that, we are building out in our genetic region, which includes Puerto Rico and the Virgin Islands. So Mark and I were in the Virgin Islands at the top of the year, and now we're connecting within our region and beyond. We have 3 affiliates, one in Belize, which the president for our Belize chapter is on Facebook. Affiliate, excuse me, and then we have Uganda and Gambia, right? And the worldview that we're taking, we're not a multi-billion-dollar operating organization, but whatever resource we have, we're looking to share, right? And to bring people together and with one viral voice, advocate for sickle cell disease. So what you're saying, we're trying, and it's happening also across the country, because we also partner with other sickle cell organizations, not just in our region, the Northeast region under Synergy, but we've established our friendships and our relationships in a broader family across the nation. But we're looking now, we're more concerned about broadening those relationships and providing support internationally, where we know people don't have access to health pay. They don't have access to the new medications. They don't have access to clinical trials, and they don't have support from their government. I mean, we complain and think about here, but we do have 3 federal bills. We got 2 bills passed in our state. The most important one keeps ending up dead on the floor, but we're working on that too. And we've made some strides. And for the first time ever in New York State, we've gotten an appropriation of $1 million
Awesome.
by the assembly. Now we're trying to get the Senate to follow suit.
Awesome.
And that $2 million is going to allow us, it's for education and detection. It's going to allow us to up our game on public education. Now we can actually pay for advertising, and we will be able to reinstate our trait screening, and particularly for men, because women, we go to the doctor. We're going to find out one way or the other, but men don't find out that they carry a trait until a child is born with trait or disease. And so we want to take this advocacy, this education out in the street, and we will finally have the money, appropriated by the state to do that. And we're hoping that the governor, send a copy of this, will understand the weight of putting this $2 million in the budget, because sickle cell, one person alone in sickle cell by the age 35, 45 costs $1 million to treat per year if they are severely impacted, right?
Absolutely.
How much money could we save the state if we kept people healthy? If they had a health team? I benefit from having a health team. I have a doctor for everything. I had doctors that I didn't even need, but when I did need it, all I had to do was make a call. I had a cardiologist. I'm like, I don't have heart problems. I've been told my heart is perfect, right? But when I had to have surgery, I needed a cardiac clearance. So I just said, hey, Dr. Freeman, can I come see you? Done deal. I have everything, but everybody else doesn't have everything. And even just right here, everybody, because the education about having a medical team in your medical home is not common knowledge. And, Tony, we have this conversation with, well, I can't make 2 meetings a month, but I make 1 a month at least, and talking about capturing people lost to care, and for them to understand that they need a primary, not just a hematology. My hematology isn't my primary, but all of the other people, and he refers me to his colleagues who are at the top of their game, have the best doctors in New York, right? Everybody needs that, no matter what their insurance is. But what about the people who don't have insurance, who don't have political support from their heads of state, from their legislators? How do we help them? How do we help poor countries gain access to these things? Now, Forma is part of a multinational company. And one of the first questions I asked, from your company and from a competitor who also got picked up by a multinational, how is access going to be made and affordable? Hydroxyurea is being tossed everywhere, and we understand that it's cheap. And, I've seen in the New York Times comments about, well, it's cheap, why don't you just put them on that? Why does everybody else have choice, but we don't get to have choice, right? We have 3 new medications and a bunch that may be coming, going up for approval by the FDA to be commercialized, right? And also gene and cell therapies. They need to be affordable because the majority of this population is on Medicaid and Medicare. And for the people who are working and have insurance by their jobs, the premiums are through the roof. And so now they don't have access. So how do we do this? And I understand, most people don't understand the cost of bringing these things to the commercial, to market, right?
Address some of the questions. So the question you had is, how do we get access to global audiences and audiences that are underserved and underrepresented in the US? I'm going to start with the global thing. So remember I said it's money, time, and people, right? And that applies anywhere in the world. It doesn't matter if you're in Africa, India, China, Japan, whatever. money, time, and people. The philosophy of what needs to happen doesn't change. But the question is, if you live in Africa, for example, in Nigeria, where your annual salary is like $100, right? How do you pay for a drug that is approved and costs a lot more than $100? And unfortunately, and again, I told y'all I'm blunt. Unfortunately, the reality is that you have to start from the bottom, because that's where we are, and build to the top. We're not going to ever go from where we are right now in Africa, where there's hydroxyurea barely available, to gene therapy in one fell swoop, right? Every company doing drug development in sickle cell disease and any other disease believes in equity. They believe that everybody deserves good care, everybody deserves good medicine, and everybody has to have access. But the how, it's complicated. The how you do it is complicated. And it has to be what we call public and private partnerships, right? Because you cannot, as a country, abdicate your responsibility to your people to the private sector or the international NGOs and think that that's going to be sustained. That's how we've done it so far. It's all been NGOs coming in and giving, companies donating, and 100 years later, where are we? We're in a non-sustainable healthcare system in these countries. And so there's a group called the Global Sickle Cell Disease. It's a group that is a combination of World Health, UNICEF, and all these big international people who work on healthcare access for everyone. So they do the vaccines, the malaria, the TB, et cetera, right? They've been talking with industry and with countries for the past maybe 10 years. And finally, they've launched this initiative that is going to go live this year. And it really is to address what you're saying, Ginger, which is, how do we do this country by country? And the things that need to be done, actually, you start with screening. So newborn screening we have in America is a luxury in other countries. Many countries don't screen people because they can't afford it. So newborn screening, education, basic education, penicillin prophylaxis, hydration, palpate your spleen, where America was in the 1970s, needs to be started in many of these countries. And yes, industry and other NGOs will contribute, but the biggest part of that initiative has to be working with individual governments and sharing with them what would be a good model that is sustainable for your country. Say Uganda, what will work with you, Uganda, for you to sustain newborn screening and basic education? Forget about going to the new drugs. We just have to start with, if you take penicillin every day and you know you have sickle cell disease and you drink a lot of water, you're going to survive to age 5. Simple. And then we think about adding hydroxyurea, but you can't go from 0 to 100 in one fell swoop because you want it to be sustained. We don't want to do a wonderful job in 2023, and then in 2033, we're back to square one, because that's what's happened. Companies have donated a lot of drugs, a lot of resources to countries, and they get a good report after 3 years, and then they leave, and then they go back to where they were before the company came in. That actually is worse, because now you're denying people care versus not giving them care. And so there's a global initiative right now for Africa, where you have the majority of sickle cell disease, looking at country by country, how do we partner, get the public sector, get the private sector together to begin to talk about customized country-specific sickle cell care work plans for your country. So where your warriors can come in is tap into that initiative and let their voice be heard. And let their voice be heard about what they need. I think we kind of know what they need, but then how they need it. Because how I would educate in, say, Gambia is going to be very different than how I would educate in Egypt. You know, one is a Muslim country, one is a non-Muslim country. You can't take the same approach to those two countries. Depending on what their financial situation is and how many people with sickle cell disease they have, you got to tailor. Nigeria has 100,000 babies every year. You're going to have a different plan for Nigeria. It's going to have to be state by state in the country and not just roll it out at the country level. Whereas Sierra Leone is a small country, the size of one of the Nigerian states, you can do all that in one fell swoop. And so it's going to be a lot of grassroots led work, beginning what you guys started about 20, 30 years ago in Africa, in India. you can't jump over the process. You can't jump over the steps. You have to start with, who are my partners? What's going on the ground? Let's sit together in a room and come up with a unified plan. How do we get it paid for? How do we get it sustained? That's the tricky part. How do we prove to my government that if you release this amount of money every year for sickle cell disease and they get healthier, is going to cost you less? You know, there's a financial plan associated with doing more upfront, you save more later on. They just have not had the chance to do the mathematics themselves. And then, for example, with newborn screening, if you screen 1 million people, it's a lot cheaper than 500 people, because the cost of the test goes down. It's demand and supply. If I screen many more people, I'm going to pay less for the material because I can produce it at a cheaper rate if I produce more. So those are the kind of things when I'm talking about. I'm not a business person, but we need the business people in this conversation to talk about the sustainability component. We need the marketing people, the communications people, and not just the heart bleeders and the scientists, because we've been doing the heart bleeding and the scientists for so long. We know the science, but we don't know how to sustain the science and the impact of what science can bring. And that's where the sickle cell field needs to go. Even in America, we need people who understand money to help us understand what are the rules of playing this game in a society where money is tight. Because there's ways of doing it that I don't even think we all know about. But people have done it before in other diseases. Let's learn from them and figure it out. But we have to get outside of our network. And that's where we don't know. Like, I don't even know, I know one banker, you know, in Carolinas, and I live in Boston. So we need to know, who are these venture capitalists? Who are these? And that's what this initiative is looking at. Let's find other people who know, who are the fundraisers, who has the skills in negotiation across government lines. Because if 3 companies combine, maybe they can get things even cheaper than if they do it individually. So those are the kind of skills that we need. Again, we got to skill ourselves for the discussion today way more than we did it before.
You're so correct. I mean, I don't say that we're just realizing or figuring out. I think some of us knew these things before, but you know, You're so correct. I mean, we're I don't say that we're just realizing or figuring out. I think some of us knew these things before, but unfortunately, we have a community who thinks in want and not in I can do this regardless of what I don't have. People quick to think about. Well, I had a conversation with a young person this morning who was stressing themselves out about a simple thing, and they said, "You know how I think?" I says, "No, I know how you choose to think. You have to not. You have to choose not to think in deficits. That there is a possibility, and whatever it is that I have to do to get to that point, we have to do it." So last year and this year, as part of Synergy for the ECHO 2.0, Mark Goodwin, our social worker and program director, and I did 3-part series. Last year we did strategic fund development for nonprofits, and then this year we did organizational development and strategic board development, right? Because some organizations have great boards and others don't. We have people on boards with names but no bodies and no action, and how important, talk about how important that is. But when we talk about developing an advisory board or even starting an organization, you don't just pull in your family and your friends. And I need to look. You need to go after people with the skills that you need. And the thing is, you have to start with yourself. What am I doing this for? What can I bring to the table? Who do I need to help me do this job? That, first, if you're going to ask your question, because I want to start this organization because we need. I always tell people not to discourage you, but did you look to see what was already in your community?
Yes,
How we're
yes,
doing
that's
that?
a very
Why don't
important.
you go over there and help that organization? Because what organizations always need is another person with
The heart.
time, skill, heart, dedication, with all of those things. They need passionate people. And when you go work for this other organization, especially one that's been around for a while, you are going to get to know how a nonprofit is supposed to be operated, right? You're going to learn. You need to learn that. When you're starting a business, there's SCORE, there's Small Business Administration. They tell you plan, vet, market, and all of this stuff. And in the nonprofit sector, those same things exist, but people don't take advantage of it. They don't learn how to start a nonprofit organization and what it means to be a nonprofit director. But going back to building the resource, the financial people, the real estate people, the strategic, business development people, we've started to build that on our board and be able to bring that information, because we do look at HIV/AIDS, at cancer, at diabetes, at Cooley's anemia. They're the smaller one out of the things. But when we look at the numbers, I saw some the other day where it talked about diabetes, rare disease globally. And there's a new initiative by the UN about rare disease, right? They say approximately 380 million. We got about 350 million with sickle cell. Our numbers are comparable to the whole rare disease community globally. And we are not making the same strides. So first of all, we need to understand what we don't know. 2, we have to stop operating in fear. And
Yes.
3, we need to look at the examples that are already being shown to us by successful rare disease and I call them diseases of affluence, like diabetes and hypertension. Look at these disease conditions and follow the path to how they became multi-billion concerns. And the first thing was that they talked about it.
Yeah.
Closed mouths don't get fed. Squeaky wheels
Get
get oiled if somebody is tired of hearing it squeak, right? I had to go buy 3-in-1 oil to fix my door and my locks for the office, right? Now I'm happy. Everybody, we don't have to struggle to open the locks anymore. We have to start talking about sickle cell in our homes, in our building, in the community, publicly. We can talk about a lot of other nonsense on social media, but let's talk about sickle cell. And I think that once we start being more visible, things will change. Most importantly, we talk about Africa having the largest population. India is right behind Africa, because it's the second country with over 1 billion people. Southern China, Southeast Asia, the Mediterranean. At one point, Greece had more people with sickle cell per capita than New York, but we don't see their faces. We have to start engaging when we talk about international, not just people of African descent with sickle cell disease, but everybody else. We need to pull them into this conversation because, again, the perception of sickle cell being just a Black disease or African, from the African diaspora is what's also hurting us politically and monetarily.
Absolutely, absolutely. And I'm going to pivot from there to talk about research and clinical trials. So you asked me, you've heard about diversity in clinical trials, equity in health, and how do we solve for that? And I've thought about this a lot. In 2010, I did a clinical trial at Emory. It was a randomized placebo-controlled trial. So randomized, some people got the sugar pill, some people got the medicine, and it was vitamin D to see if that would help improve your pain. And I had a budget of $50,000 and I needed to look at 60 patients. And it was going to be 2 years. We did that study under budget. I think I gave them back 15 grand and we finished it early. And I didn't really know that there was an issue with clinical trial recruitment across the world for sickle cell disease until I began to do that study. But the surprising thing was I turned people away who could not participate because they didn't meet the right check boxes, right? And they were not happy with me. Like, why can't I do it? I want to do it, I want to do it. And so when I did that study, I began to do a digging into what's been going on in sickle cell disease. Sickle cell has the most trials, research studies, that have closed because they couldn't get enough patients enrolled. They have the most trials that take longer to finish. And the longer a study goes on, the more expensive it is to do, right? And so there's many, many, many drugs that could have been approved, but because we never could get the trials done, they weren't approved. So the question is why? Why is it that for the most part, trials people don't enroll in sickle cell disease? And I don't believe that it's because they don't want to participate, because I've asked a lot of patients and many, many, many of them want to participate in trials. What I've heard, and you guys, I want to hear from you, Tony, and Ginger. Nobody tells us about it. We don't know it's happening. It's not convenient for me to participate. Well, I don't want to get the sugar pill. I didn't really understand what they were saying. I don't like the doctor, or I don't like the nurse, or they made me feel some kind of way. Like there's other reasons than I don't want to participate, and so I'm going to pause and kind of say, Tony, maybe you can kind of tell me, what are your thoughts? What have you been hearing on the ground from people living with sickle cell disease around why they do or do not participate in clinical research or trials?
Mostly they don't know about it. And so the research offices tend to be off in their own little silo in the hospital system. And one of the things we have started doing as of last year, the research staff who are doing the projects about sickle cell disease are coming into the clinic. So they're part of and they're also getting to know the nursing staff. So increasing the staff's awareness of what's going on. And also the support group meetings in the local sense and in the combined sense, because we have a statewide initiative, is to keep broadening who knows about it. The other thing is to increase the PR within the healthcare system. We're 11 hospitals and trying to get each of those hospitals to move in the same direction. By now, there is in our system a much increased PR focus to do. And so it's putting that information to the general public who comes into each of our hospital buildings, but also to the staff who are in all these different departments. And collectively through synergy, through echoes, getting more different people in different aspects of life and different skill sets to be aware of what we're doing.
And that seems like a very simple problem to solve for. Let people know. And so the way it works, you mentioned it a little bit, Tony. The doctor is the PI, and I'm working in clinic, and I have like 20 patients in a day, and I'm overwhelmed and stressed out. And my coordinator is in the research office. And if I happen to have a minute to myself to think about it, and I remember, I'm like, oh yeah, come and see the patient. By the time they come over, the patient is gone because they waited too long. Or I talk about it in a hurry, and then the patients, I'll think about it next month, and then they miss their next month's appointment, and then they come back in 3 months, and then I forget, and then they forget. Like it's very chaotic. And so I think one wonderful opportunity that SCTPN has is to be the disseminator of this information. Share with your networks. Hey guys, do you know what a clinical trial is? Okay, let's talk about that today. This is what a clinical trial is. We need minority representation in clinical trials. Why? Because if we don't have the right people in the trial, when the drug gets approved, we don't know if it's going to work for y'all. And a lot of times, I don't know if you heard about the hypertension studies in the 70s and the 80s. All those drugs were great for high blood pressure, just not for Black high blood pressure. You know, and there's several different things like that, several different studies like that, where the majority of the people are Caucasian white men, not women, and not BIPOC, not minority. And so you wonder why women have a higher heart attack rate, because we never studied them to see what would help them, right? And so when it comes to sickle cell disease, I think that first they need to know that these studies are available, these trials are, and they need to know what a trial is. Trial, research, study, it's basically to get you a new medicine, we need to make sure that it's safe in animals. It's safe, well, it's safe in the lab, it works in the lab. It's safe in animals and works in an animal. It's safe in a healthy volunteer, and we know what the side effects are. And then in healthy patients with sickle cell disease, we try to get the right dose and make sure that it's safe before we go to everybody else to do what they call the phase 3. The phase 3 is you have to make sure that the medicine is not just as good as having a sugar pill. So half are going to get the medicine, the other half are going to get the sugar pill, and they're going to compare, and we're going to see, does it work the way we think it works in healthy people, in animals, and in healthy people with sickle cell disease. That's what a trial is. And without going through that process, you're not going to get any new drug available for sickle cell disease. So the beginning of improving options is being a part of the trial development process. Now, most of the time, I sit in my office with my people in the research lab and wait, oh, this is going to be a great idea. Let's just go ahead and we do it. Then we now say, Ginger, do you want to be a part of my trial? You had no idea what was going on in the beginning. You had no idea what we're talking about. And you're like, okay, maybe, maybe not. How much more wonderful would it be? This is patient centricity, Ginger. If when we're thinking about a trial of sickle cell disease, we want to say, okay, what kind of things do sickle cell people need us to solve? We sit in a room with you and your colleagues and say, Ginger, what's the most important problem you guys face? Is it pain? Is it fatigue? Is it anemia? Is it headaches? Is it AVN or whatever? You tell us, we go into the lab and we say, okay, we have 5 different options to treat these 5 different things. We come back and say, hey, we have these 5 options. Which one makes the most sense? You help us rank it. Then we go back and we do more studies to say, okay, does it even work? We say, okay, fine, this works. Now, how do you think, Ginger and sickle cell people, that we can use this drug in sickle cell disease? And every step of the way, you are advising us on how best to do this. And the most important piece is the clinical trial and making people know about the clinical trial. If you are part of the development, you're going to be talking about the trial. If you are part of designing the protocol, you will tell us, Iffy, I don't want to come 25 times this month. That's just too much. Can we not come like 5 times or 3 times? Figure out how to make it 3 times. Iffy, 3 times a day pills don't work for me. I want to take it in the night or take it in the morning. Or the pill is too small, the pill is too big. Whatever you tell us, we are now going back to the lab to see how we can make it work. Because if we want this drug to help you, it's not for me. I may be the one developing the drug, but it's no use if it doesn't help you. So if you help us develop the drug all across the way, how much more effective will that be? You know the right people who need it. You know how they're going to take it. You know what they will tolerate from a side effect profile. You know how much benefit they want at the very minimum to get from any treatment. At the end of the day, it makes everything work better, and it allows for the medicine to get to the pharmacy, so you can go to CVS or Walgreens and pick it up at some point. Typically it takes
Right.
17 years. 17
Yeah.
years from the concept, and then when you now get to where the drug is available, it's another 7 years, to get it to a patient. So 10 years in the lab, and then another 7 years in the research setting, and half the time none of it works. But it may not fail because it's not a good drug. It may not fail. It may fail because the patients don't like it. It didn't work the way they wanted it to work, or the side effects are not the ones that they can handle. Like, some people can handle nausea, some people can't. Some people can handle a mild headache, some people can't. Some people are like, shoot, I'm always constipated. So if I get a little bit of diarrhea, that's a great thing. But we wouldn't know that if we don't talk to you people, right? And so we need to make sure that there's this back and forth communication. As we develop drugs, we need desperately to develop it to suit you, not to suit me, because I'm not going to be one taking the medication. It's kind of like, if you want to go for a wedding, you want to buy a dress, and I'm giving you pantsuits and you want a dress. You're like, I don't want a pantsuit. I want a dress. So why would we make a pantsuit? It's all clothing when our customers want dresses to go for a fancy event. I mean, if you look around, evening gowns are it. They didn't just come up with that because they want to do evening gowns. They talk to people. They do what they call market research. And they're like, oh yeah, women look elegant in the evening gown. You can put your hair up, you can look nice. So then marketing does this all the time. Starbucks. What do patients want? McDonald's. What kind of foods do patients like? When they did the chicken wings, that was an epic fail. They started that one a little bit and it disappeared. People didn't like it. That's what we call centricity, where you're engaging the community to be a part of the development process. That is what we need to start doing more and more of. But we need the community to partner with us to be able to do that, because you're right. It is extremely expensive to develop a medication. And if you don't do it
I
right.
want to touch on that though. Excuse me, I'm sorry. I want to touch on that because the community is doing it. But here's the conundrum. So here's the thing, Americans don't like to read anymore. We are daily, and Vivian is our trial informationist. She's the one, everything she picks up, she posts it straight to social media, right? We have 2 Facebook pages, we have 2 LinkedIn pages, we have Twitter, Instagram, and so this information goes out, people are not reading it. And I got frustrated one day and I said, hey people, we're putting this information here for you. Would you please click the link and read it? And so I just, typed it in the Facebook chat. Hey, we do post information on trials. We need you to click the links and read about it. So what we started to do with our marketing coordinator was take key points out of the literature for the trial and make multi-page memes. People will watch the videos. So we'll put the words, and not too many words on one page, and we can have up to 4, pages on the meme. We'll put it in there and they'll watch that video several times to catch everything that it says. We get better response from the videos than the links to the actual trial data information, right? But one thing we haven't been doing that, and when I say we, I mean me, and I don't really want to do it, is more video to get in and talk about it. But we have, as an organization, been educating the population about the importance of participating in clinical trials since 2017. We've had town halls, we've brought people out who were on trials, people who, were skeptical, talk about why they were skeptical. And, there's a lot of magnetic resonance from past harms done to our people in research that we're saying, okay, that's not the situation today. But I noticed that folks would jump on a cancer trial, no hesitation, because it's been, how can I say it? It's been Hollywoodized, it's been glamorized, everything cancer. And, even though, what was that? Grey's Anatomy did have a couple on things on sickle cell, it was always just about the pain and medication. They didn't talk about clinical trial, they didn't talk about anything else. And anytime you see something about sickle cell on TV, it's always about the pain and the stigma of being an addict. We need to go beyond that in messaging. And so if you can volunteer to do a clinical trial for cancer or a headache or anything else, come do it for this because we need the data. We need you to stay in it. If you feel like you want to drop out, call us. We'll come hold your hand all the way through to the end. You know, you got to stay because we now have the benefit of, well, there were 3 medications. And like you said, because they didn't talk, there was no centricity. One of them failed. And so they pulled their whole commercial, you know, commercialization across the country. But the people who were on the trials and who are benefiting from that medication are still on it. But, you know, in order for everything else to be successful, we need to get the people out and get them there. And I think the other thing that we need to do that hasn't been done, and we've been asking people to do, and now I have to, you know, point the finger at myself. It says 1 at other people and 3 back to yourself, is to talk about it openly. And I have been, and I think I disclose, and people are like, I'm not supposed to know this. You can't tell me this. And I'm like, well, I'm happy.
Who you disclosing to? You can disclose it to anybody except for certain people.
I'm thinking I want people to be happy that I'm happy. So I'm on a clinical trial, and in one month on, you know, in open label extension on the actual drug maximum dose, my hemoglobin went up 2 grams per deciliter. And am I not an excited person?
So how was your experience on the clinical trial? Because a lot of people are nervous.
I am, well, people who know me can know I can be very clownish, right? So first of all, I have traumatized one of the nurses at the trial center because he's afraid to draw my blood, you know, the bad stick thing, you know. And I go in, and, you know, the nurse who was doing it before him and, you know, was kind of trying to ease him into being the one to draw my blood. She likes to go in the finger. I have a vein, and she just wants to go right there. And I'm like, my finger is going to collapse from, you know, hyperanemia. You can't just keep going in one vein. It won't be there anymore. We need to go access other veins. So when I say, okay, we're going over here, we're going to beg, and he's like, oh no, I can't see. And I said, see, that's your problem. Stop trying to look for it. You've got to feel for it. But I've already done the job. I'm telling you, it's right here. Go for this pain, right? It's difficult in the beginning when you got to do the 9 tubes.
Yeah.
And you got to do that for like 2, maybe 3 times for 2. But it goes twice for 9. Then it goes to 6. And after that, it's 3 for the rest of the year, right? A lot of people are not going to want to do that. Me, it was like slapstick comedy. And doing the blood draw because, you know, I had this real paranoid nurse about having to stick me more than once. And I was like, you're going to have to get over it because you're going to have to stick me more than once. We have to get 9 tubes of blood. If it's 3, we can manage it out of 1. But sometimes, you know, it's like, I'm not coming out today. And I'm like, okay, I can feel my veins blow. I said, that's about to blow. You're going to have to just get what you can now. And we got to go to another vein. Right. And that makes him crazy. And I'm like, listen, I know you go home to your wife and you talk about me. I don't want this woman to hate me. So you better be careful what you say, because if I ever meet her, I don't want to have to tell what's really going on in here with the 2 of us, right? And so it's been like that for 2 years, you know. And when I got my first, you know, box of open label extension, took pictures with the 2 doctors in the trial and everything. And I'm terrible about posting, so I do have to post that. I'm going to post it today, folks. And it has been a great experience because I, like many people that I know, particularly people who deal with hemolytic anemia and not VOCs, are being told we're too healthy.
Yeah.
And that's a barrier too. It's not just, you know, not knowing is the biggest thing, but also being told that you're too healthy because you don't have 2 VOC hospitalization or emergency room visit on record. We don't know that we need to record that. Sometimes, you know, most of the time people are managing at home.
Yeah.
Right. When I had the 2 crises that qualified me to get on the trial, I was actually at a conference, and it was because of that conference that I actually got sick. It was not a refrigerator. It was an ice box. It was sub-zero in that place. And I had to keep going outside, and thank goodness it was 90 degrees outside to warm up. But I ended up having those 2 crises from the exposure to cold for long periods of time. And so I called my doctor, and I was like, I need you to make that a record, put it on record, because I knew that was the only thing that was going to keep me from getting on this trial. And so people have to start reporting. If you're managing at home, call your doctor, say, I'm managing at a crisis at home, and then go for a follow-up visit. If you are in the ER, usually if it's at your home hospital, it's fine. Your doctor's going to find out about it. But the ER I go to is not at my home hospital. My home hospital is in a, next village over. And so they call my doctor, and then I'll go for a follow-up or call him and say, I went for a treatment. So we have to make these things a matter of record, but also now to get with the FDA and talk to them about VOCs is not the only thing that should be a
Outcome measure of
qualifier.
interest.
We have to,
Yes.
because a third of the population is hemolytic anemia, and the damage is happening very quietly behind the scenes, and you don't know until you're in stage 5 of a complication when that pain, that different pain shows up, and it's like, what the heck is this? And then it's an AVN, or why is my vision red? It's a retinopathy, your retina just detached, or your children are yelling at you because you're not listening to them and didn't realize that you were experiencing hearing loss.
You said something, Ginger, that we need to probably repeat, is that some people with sickle cell disease have pain that they manage a lot at home, but not a lot of it when they go to the emergency room, right? And some people only consider their pain in the ER as significant pain. Now think about in Africa or India. You can't be going to the emergency room. They don't got it like that. You can't spend your $100 a year by going to the emergency room. Many of them don't go to the emergency room. They manage it at home. They pick up, pain medicines here and there from the pharmacy and stay at home. So there's different types of sickle cell disease strategies to manage the pain. And going to the ER is one. Managing it at home is another. There's no judgment there, but it's still a pain episode. And I think sometimes people underestimate the severity of your disease because you don't have an admission. Oh, she's doing fine. She hasn't been admitted to the hospital in a year. She's missed 6 months of work. So how do you document that? How do you make sure that people know that just because I'm surviving doesn't mean I'm thriving and I deserve good care in addition to the people who are in the emergency room? Some people don't live anywhere near an emergency room, or the ER is not the place they want to go. Maybe in some rural area where they don't know anything about sickle cell disease, but they still have problems,
And that's true. And again, because we don't talk and we have to document these things. And, there's no real statistics being outside of clinical trials, and they're asking you certain things. And some of the questions is like, well, this is not appropriate. It doesn't really relate to me. But it's a question that's being asked. And yes, information is being collected, but it's not always relevant information, and the thing is, we have to speak in patient registries. I know a lot of people are afraid of doing patient registries. And I was encouraged for our organization and our network to start one because of the information that can be collected. And one of the things that I was interested in about the patient registry is the learning about comorbidities and the onset and being able to see patterns in onset in each things like pulmonary hypertension or avascular necrosis, retinopathy, hearing loss, nerve damage. When do these things start? And we need to get to that space, because when you look at diabetes and what companies like OM1 are doing in terms of AI and catching individual micro and macro data, and what they're pairing it to is, aside from medications that are already available for diabetes, they're looking at other medications that could be repurposed, particularly for complications.
Patients, yeah. And we need to do that for sickle cell disease, but we can't do
that for
if
sickle
we don't
cell
have data.
So now I'm going to have to do more videos to say, hey, people, we're going to start a patient registry. If there's one in your state, get on it, because, and here's my fear, my personal fear about patient registries and collecting the data. So we see that number 100,000 continue to be floated for the last 50 years, right? Everybody knows there's more than 100,000 of us. It's more than possibly more than 200,000. The last 3 in NHLBI meetings before the pandemic, I said, hey, that number, somebody came up with that number when there was a lot less people on the planet. Now we have 2 countries with over 1 billion people. 200,000 is
Doesn't make
not
sense anymore.
an equitable number. It doesn't make sense anymore. Not only that, sickle cell disease is the largest population, and I know y'all are keeping us in 100,000 to keep us in orphan drug status and rare disease status. But if you really start to count us, are you going to now kick us to the curb because we've gone over 200,000 people? You need to change that number. Change the number, change the number, change the number, change the number. Because if we really start pushing this patient registry, and we can show, because the national TDP has the registry to do longitudinal data. If you see that there's more than 200,000 of us, because what you're not counting is immigrants, documented or undocumented, you're just, and it can't be the same exact number of deaths and births happening every day.
At the same time, yeah.
So let's get the real count, but then let's make the changes to accommodate whatever that number is going to be here in the United States. We need to know, because all of our organizations across the country want to be able to help every one of these individuals and families, be there for support and get them into the path of just the things that we were talking about today: knowing your disease, taking care of yourself, working with private and public industry, working with the physicians, with the hospital administration. Now let's talk about them. When the doctors say they can't do it, right? And stop yelling at your doctors, folks, because they are bound by hospital policy. They're an employee. And I know, I do know of health practitioners who have been fired from their job for doing what they knew they needed to do for their patients.
Yeah.
We don't need to lose good people, right?
Yeah, that's a good point. It's a good point.
Yeah.
It's the hospital administration, they pay your salary, and they have policies, and they have rules that we have to follow when we work for them. Now the doctor typically uses their best judgment to be able to follow the policy, but if the policy says you can't do something, you can't do something. If you do it, you're going to get fired. And that's as simple as that. Now, a lot of times, part of that education needs to be to the hospital administrators, because all they know is what they hear. Oh, sickle cell is all about the ER and the pain. They don't know the patient journey. They don't know how much suffering. They don't know anything about sickle cell disease that is other than they go to the ER and they use a lot of pain medication. That's all they know. So part of our job is to educate them about the patient journey so that they understand that a sickle cell individual is kind of like somebody with diabetes that has multiple organs affected, plus they have pain. So it's not just pain. It's kidney, it's eye, it's hearing, it's heart, it's liver, it's lung, it's spleen, it's joints, it's nerves, it's skin. But they don't, strokes, they don't know that. They're not medical people, they're financial people. They see the dollars and the cents, and it's not adding up. That $1 million a year on that patient is costing them a lot of money. But we have to let them know it's not just that they're in pain. The person who's costing $1 million a year is sick with many things. Maybe from sickle cell disease, but maybe in addition to sickle cell disease. But then they lump all the cost to sickle cell disease. But he may have diabetes, high blood pressure, pulmonary hypertension, gout, kidney disease. Some of it may be because of sickle cell, but it may not be. But it's not the sickle cell's fault that they have this extreme cost. And so that's what we have to teach them about, the fact that the people that they don't see, the majority of sickle cell disease is not the ones in the hospital. A hospital is 3% of the whole population. Thank God it's only 3% of the whole population. But to your point that there's more than 100,000, that's a big number. But can you imagine what's under the 3% who are suffering silently and not in the hospital? We want where they don't have to go to the hospital. We want them to not live in the hospital, keep them healthy before that severity kicks in.
Or comprehensive treatment programs, and particularly in adult care, because our young people are aging out of pediatrics into nothing. They're falling into the abyss. They're getting lost. We all have these conversations about adults lost to care, and it's because there isn't comprehensive programs. It's because adult medicine isn't educated and trained, and it's also because of the people who come before them are not doing the advocacy that needs to happen. Adults need to take responsibility, and you need to stand up. I've always, even as a child, had a relationship with the administrators in my home hospital, the president, especially the president's secretary, the director of patient advocacy, the ER, the chief of staff, you know, in pediatrics, the chief of staff was the doctor who diagnosed me, right? And so when I got to adult medicine, anytime they didn't act right, I called them and I'm like, hi, I'm in room so-and-so, come see me. And so he comes, they see him walk onto the floor, right, and walk into my room, and everybody, I've had memos in that hospital about me, honestly, and I didn't mind.
We don't want everybody to have it that way, but I want to
when
touch
he
on.
was leaving, I would walk out, put my arm around him, walk him to the elevator, and say, thanks for coming to see me. I'll come to the office and see you. And people knew not to mess with me. I got what I wanted, right? Everybody has to find a tactic, right? And talking to administration.
Talk about transition.
Yeah. Okay.
I want to talk about transition because that's something that is near and dear to my heart, and I'm very excited to share that we were fortunate enough in 2017 to get a grant called to do a study called the Step Up Study, and you guys were part of that study. And basically, it was a grant to help us figure out a way to standardize how we do transition from pediatrics to adult care in 14 different hospitals across the United States. So that was an adult clinic and a pediatric clinic and a community-based organization as a partner across these 14 sites. And SCTPN was the partner with Montefiore, which is, we are so thankful that you guys kicked butt and took a lot of names, because we working together, again, that's the community, the pediatric and the adult hospital medical people working together to put in place this structured process so that every teenager who comes into sickle cell disease clinic gets the same kind of care all across until they turn 25. It's 16 to 25. And we were able to work together to figure out a way to engage them, to educate them, to support each other, and then to put a process so that even if Ginger is not there and Mark is not there and Dr. Mawani is not there and Dr. Katerina is not there, they get the same kind of care. There's a protocol in place for every patient when they show up. And I think that is the most impactful thing I have been a part of in my career as a sickle cell doctor. And we were able to show that even though the adult clinics began at a lower level of competency, like they didn't have all the stuff that the P people had, by the end of 5 years, the adult and the pediatric programs all scored over 90% on putting in place this process. And I'm sure there's a lot more work that needs to be done, but having a protocol to follow, oh my God, that is something that has not existed in sickle cell disease transition ever. So I'm very excited about that.
So I have good news with you on that. So Mark has stepped back and we have turned over the cab to the adults, to the young adults. So we had one transition adult from pediatrics is the vice president of the cab. And yeah, so they're doing their thing, and so excited, so happy for them. You know, Andrew still is coordinating. He's there to provide support. The new social worker now, but now the young adults are running their cab. So we're really so excited, and we have a new cab at Kings County Hospital. So we're going through that, and we're working on developing the transition piece, but right now we're just kind of galvanizing the adults there and telling them who we are, what we do, what we would like to see happen with them. And there is going to be a move. So the adult program is supposed to be moving in the same building as the pediatric program.
Awesome.
And so we'll have proximity to be able to do transition a lot more easily between at that particular, and then I'm on the hospital cab and like 2 or 3 subcommittees. So it's like, and I like what I'm hearing. I like the directions that they're going in and things that I think that they're missing. You know, I just kind of mention it and they're like, okay. And one of the biggest thing is like, okay, clinical trials. You have a clinical trial coordinator here who can bring trials. And I'm not just talking sickle cell. We have other conditions, rare diseases. And some of those trials, like anything to do with retinopathy and stroke and pulmonary complications and things, sickle cell needs to be on that too. And we're not in these pipelines. So I've been pushing that as well, not just telling people join clinical trials, but telling the companies, hey, sickle cell has that. Can you put us in your pipeline, please? You know, when you're testing drugs for retinopathy and stem cell treatments and things, can you include sickle cell? Because we have the same retinopathy as diabetics. You know, I was looking, I think it was Jensen, and they had something for thrombosis, right? we absolutely need a study about that. So many people are developing, they don't know that they have S or C protein deficiency until they develop the first clot.
Yep.
And hopefully a doctor knows, do the coagulation study before you start them on anticoagulant, right? But if that happens, you know, there's this study. And so we're trying to make sure that that's also happening too, that companies are taking a look at this condition and understanding, you know, they can benefit from having our population in their trials because we have the numbers and we have that complication that they're trying to develop their product on. I thank you so much. We're going to have you back. So I'll give you a couple of months to rest. We want to have, because this has been a rousing conversation. Have another conversation about transitions, you know, and next step after, since the PCORI grant is over, and we're talking about, you know, developing new relationships in hubs with the 14 CBOs in the hospitals. We need to keep that going. It was so vitally important. And again, you know, goes back to the whole Project ECHO thing. You know, we're on ECHO with HHS, with Jacobi Hospital. We're in ECHO with Synergy, and we're establishing an ECHO. But what we want to do is refer, you know, healthcare providers to the PC to PC ECHO. And then we do things that's more community-based, like the transition ECHO, creating a caregiver ECHO, you know, you know, speak out, different things to kind of engage the community, and because that whole process with ECHO is absolutely amazing. It's entrenched, it's global, and we'll be able, what we can do here now, we'll be able to translate that and develop those models for our international affiliates too. So that's really our long goal, is to be able to bring that model to other countries and to help the community itself to be educated, to help them to educate others, and then eventually to get those providers to come in, listen to the experts, listen to the cases, and be able to feel confident that they can do a job and not refuse to care for somebody because they're afraid of doing something wrong. And like you said, you know, at the top of the conversation, you have sickle cell, if that's active, treat that. But if I'm having abdominal complaints, treat that. If I have a stroke, treat that. Treat them both, but you got to treat that and not just worry about sickle cell, because our pain isn't always just a basic crisis. Sometimes it's signaling that there is a serious underlying problem. And if you don't go look for it and you're just concerned about what drug and how much I'm going to give you, you're going to miss it. And then things go very, very wrong. And we don't need to see any more severe complications and or death as a relationship to not knowing. So thank you, Dr. Ike, for coming and spending this time with us. Thank you, Tanya, for helping to coordinate. And thank you, Tony, for always showing up. And can you unmute 19292? I wonder, who is that? Who are you? Unmute so we can say hello to you.
It's Esme.
I got to give a shout out to Esme. She's one of our 2 senior community health workers, you know, and you know, so I thank you for showing up, Esme. You know, I was hoping that the rest of the team, but one of them actually just got out of the hospital. And but we have this recording, and we're going to do some edits, and we're going to use some snippets of some of the, you know, bold and very impactful statements that you made will go out across our social media platform. And if you would like to have a copy of the video, just let me know and I'll send you a link.